A young, completely healthy man goes to sleep after a normal day. No chest pain, no warning signs, no known heart disease. And in the middle of the night, without struggle, without noise, his heart suddenly stops. The autopsy shows a structurally normal heart. No blocked arteries, no cardiomyopathy, no valve disease. So what happened? The answer was there, on his ECG. Today we're talking about one of the most dangerous and easily missed ECG patterns in cardiology, Brugada syndrome. Brugada syndrome is not a disease of heart muscle. It is not a blockage problem. It is not a valve problem. It is an electrical disorder, a genetic channelopathy that affects the way sodium moves in and out of cardiac cells. Most commonly, it involves a mutation in the SCN5A gene, which encodes a cardiac sodium channel. That sodium channel is critical for phase 0 depolarization, the rapid upstroke of the cardiac action potential. When that channel doesn't function properly, the electrical conduction in certain areas of the heart, especially the right ventricular outflow tract, becomes unstable. And that instability creates the perfect setup for lethal arrhythmias. Not slow arrhythmias, not minor palpitations. We're talking about ventricular tachycardia, ventricular fibrillation, sudden cardiac death. And here's what makes it frightening. These patients often have completely normal hearts on imaging. Echocardiogram, normal. Cardiac MRI, normal. Coronary angiography, normal. Which means if you're not looking carefully at the ECG, you may completely miss it. Brugada syndrome most commonly affects young males. It is far more prevalent in Southeast Asian populations, but it is seen worldwide. Many patients are asymptomatic until the first event, and the first event may be syncope, or what looks like a seizure, or sudden cardiac arrest during sleep. Yes, sleep. Arrhythmic events in Brugada syndrome frequently occur at rest or during sleep. Increased vagal tone during nighttime may contribute to arrhythmia initiation. Fever is another major trigger. A simple viral infection can unmask the ECG pattern or precipitate ventricular arrhythmias. That's why aggressive fever management is critical in known patients. Alcohol intake, heavy meals, certain medications, especially sodium channel blockers, can also provoke arrhythmias. So, how do we recognize it? The ECG is everything. There are 3 described ECG patterns associated with Brugada syndrome, but only one of them is diagnostic on its own. Type 1, Brugada pattern, is the one you must burn into your memory. In leads V1 to V3, the right precordial leads, you see at least 2 millimeters of ST segment elevation. But this is not the smooth, concave ST elevation of pericarditis. It is not the localized convex ST elevation of an anterior ST-EMI. This ST segment rises sharply, forms a coved shape, and then gradually descends into an inverted T wave. The T wave is negative. The morphology is everything. It may resemble a right bundle branch block at first glance, but look closely. The key feature is the coved ST segment elevation, followed by T-wave inversion in V1 through V3. If this pattern appears spontaneously, not induced by medication, it is diagnostic of Brugada syndrome in the appropriate clinical context. If a patient has syncope and this ECG pattern, that is a high-risk patient. That is not someone you send home casually. Now, let's talk about type 2. Type 2, Brugada has a saddleback appearance. The ST segment rises, dips slightly, then rises again before transitioning into the T wave. The T wave may be positive or biphasic. It does not have the same dramatic coved descent seen in type 1. Type 2 alone is not diagnostic. It raises suspicion. It tells you to investigate further. Sometimes a sodium channel blocker challenge, using medications like ajmaline or flecainide, is performed under controlled conditions to unmask a type 1 pattern. Type 3 is even less specific. It resembles type 1 or type 2 morphology, but the ST elevation is less than 2 millimeters. Again, not diagnostic on its own. This is where clinical judgment becomes essential. Now here's where many learners make mistakes. They confuse Brugada with right bundle branch block. At first glance, both can show changes in V1 and V2. Both may show what looks like an RSR pattern, but the difference lies in the ST segment. In a true right bundle branch block, you expect a wide QRS complex, an RSR pattern in V1, and wide slurred S waves in the lateral leads. In Brugada syndrome, the emphasis is not on QRS widening. It is on ST segment morphology. The ST elevation is abnormal, prominent, and shaped in a very specific way. If you focus only on the QRS complex, you may miss it. If you train your eye to analyze the ST segment carefully in V1 through V3, you will catch it. And remember, lead placement matters. Sometimes moving V1 and V21 intercostal space higher can make the pattern more obvious. So, whenever you see unexplained syncope in a young patient, especially a male, especially if events occur at night, always examine the right precordial leads carefully, because Brugada syndrome hides in plain sight. The heart may look normal, the patient may look healthy, but the electrical system is unstable, and if ventricular fibrillation is triggered, there may be no second chance. Not every patient with a Brugada ECG pattern has the same risk. Some may live their entire life without an event. Others may experience sudden cardiac arrest as their very first symptom. Now let's talk about treatment. There is no medication that cures Brugada syndrome. You cannot fix the sodium channel defect with a pill. You cannot reverse the genetic mutation. The only proven life-saving therapy for high-risk patients is an implantable defibrillator. Implantable cardioverter defibrillator is not a pacemaker. It is a guardian. It continuously monitors the heart rhythm. And if ventricular tachycardia or ventricular fibrillation occurs, it delivers a shock to restore normal rhythm. For patients who have survived cardiac arrest, ICD implantation is strongly indicated. For patients with spontaneous type 1 pattern and syncope strongly suggestive of arrhythmia, ICD is generally recommended. But ICD therapy is not without complications: inappropriate shocks, device infections, lead fractures, psychological impact, especially in young patients. These considerations matter. So we do not implant ICDs casually. Now let's discuss medications. Certain drugs are dangerous in Brugada syndrome because they further block sodium channels. Class 1 antiarrhythmics, particularly sodium channel blockers, can worsen the ECG pattern and provoke arrhythmias. Certain antidepressants, some antipsychotics, certain anesthetic agents, and even cocaine can increase risk. Patients must be educated clearly about medication avoidance. There are published drug lists specifically identifying medications to avoid in Brugada syndrome. Fever management is critical. Even a mild fever can unmask a type 1 pattern or trigger ventricular arrhythmia. So when a known Brugada patient develops a fever, it should be treated aggressively with antipyretics. Do not ignore it. Another important point: lead placement. Sometimes the Brugada pattern is subtle or intermittent. Moving V1 and V2 to the second or third intercostal space can increase sensitivity for detecting the pattern. So when you see ST elevation in V1 to V3, pause. Do not rush to call it early repolarization. Do not immediately label it RBBB. Study the morphology. Ask about syncope. Ask about family history. Ask about nocturnal events. Ask about fever-triggered episodes. Because the difference between recognition and dismissal may be the difference between life and death. If you found this explanation helpful, make sure to like the video and leave a comment below. We read your feedback closely, and it directly influences the future content. Don't forget to subscribe and turn on notifications so you never miss an upload. Thank you for watching, and see you in the next video.